So good morning, everyone. And we are live now. We can go ahead.
Thanks, Ashok. Good morning, everybody from UK, and hello to all our worldwide viewers watching this live webinar organized by Northwest Education Academy in collaboration with OrthoTV UK. Thanks for joining us on Sunday. Now, before we go ahead with today's webinar, I just want to take this opportunity on behalf of NWEA to thank all our previous speakers associated with us and the worldwide viewers to make these webinars a huge success. We've had more than 3,000 combined viewers for last two webinars organized on this platform. And I think it's a great start, and that really encourages us to engage with renowned speakers like we have today to share their expertise and learnings with the viewers across the globe on challenging pathologies. Now you can see from the program here, in today's webinar, our eminent speakers will provide their perspective on few of the key topics relevant to upper limb practice in UK as well as worldwide. Few of the speakers will speak about the injuries to manage elite athletes' tendons, and we've chosen particularly two important muscular tendons unit, pec major and proximal biceps. And we've got a physio experts to see how we get these patients or athletes back on playing the sports they enjoy. We would also have a Q&A session after individual talk, and also at the end. You can use the Slido button at the bottom of your screen. If you're using a mobile phone, you might need another screen to have your questions to ask. So let me introduce our first speaker, Prof. Len Funk. I know Prof. Since 2007. He's been my mentor and guide. Prof is an upper limb surgeon at Wrightington Hospital as his NHS practice. We all know Wrightington as a center of excellence. He also has his private practice in Manchester with the Arm Clinic. Now, large proportion of Len's practice involves managing elite athletes as well as professional players, and he's evolved to specialize completely on sports and soft tissue injuries around the shoulder. He's our go-to man to have second opinion on treating complex problems, also performing revision complex shoulder surgeries. He has established and running shoulder.co.uk. People who have already visited shoulder.co.uk would be aware that it's one of the best shoulder-related information portal available for the patient as well as whosoever is involved in treating patient. He's clearly passionate about his evidence-based patient information and education, and he thrives on improving the quality of the patient care through multidisciplinary approach. He's got more than 100 articles published. He's written on numerous books and contributed to the work of others on shoulder surgery and rehabilitation. He's actively associated with universities, teaching undergraduate, postgraduate medical students, sport therapists, and various faculties. Without further ado, I would hand over the next session to Prof. Fung. Over to you, Prof.
Thank you very much. It's a great pleasure, Ravi, to be invited to do this. I'm just sharing my screen with you while I try and do this. Great. Yes. Thank you very much, everyone. Happy Mother's Day to any mothers that are joining us today. Thanks for everyone who's joining us. This is where I harp from, Wrightington. I'm very proud to be part of this very large consultant upper limb body. This is our upper limb consultants. We have a lot of specialist physios, and we're huge thanks. You can see Matt there. It's a huge thanks really to John Charnley on the right and John Stanley on the left, who recently passed. who still, we feel, look down on us and inspire us, not only to do better for our patients, but to be good colleagues. And we think of ourselves more as a family rather than an upper limb unit. And obviously anyone's welcome to visit our family anytime. So unfortunately or fortunately, I've developed a large experience of treating pec major injuries and want to share that with you this morning. So my experience really started around about 2004 to 2006 when almost nobody was repairing pec major tears. I almost got thrown out of a room for saying that I would fix them. Now I get thrown out of a room for even suggesting not fixing them. It's amazing how things have changed in such a short time. So what I want to just share with you, this is my experience and highlight to you, that's the numbers. But if you have a look at the numbers that I see and the numbers that I operate on, the conversion to surgery in my practice is 50%. So, you know, just want to say to those young surgeons, you don't have to repair every pec major tendon injury, because that's the way things have moved at the moment. There is a place for non-operative, and hopefully I'll highlight that to you. My experience is largely with athletes as well, the majority, and you can see the majority are rugby players. So we typically think about it as a bodybuilder or weightlifter injury, but by far and away, the largest number that I see are rugby players. So a little bit about the anatomy, because many of our books are wrong. And this is certainly one book that I highly recommend, which is the Atlas of Functional Shoulder Anatomy. So some Italian anatomists did these amazing dissections and beautiful pictures. But what you can see is that the clavicular head of pec major and in this one, the sternal head, actually don't fully attach just to the humerus as we're taught, but they attach to this myofascial condensation, which becomes part of brachialis, biceps and deltoid. And you can see that beautifully there. So it's not strictly as you see. Generally, however, well, almost always, the sternal component, which winds underneath and spirals like this, does attach to the humerus, and that's the tendon that avulses in the majority of cases. You can have clavicular involvement, but the vast majority, it's the sternal component involved. The other thing is that the attachment is over a footprint, over a broad area, and there's a nice paper on that as well, which shows that there's a broadish footprint of attachment, which you want to reproduce anatomically. Clinically, a lot of patients know when they've done it, but a lot of physios, when they'll see a physio or go to any or doctor, they'll say you've torn your biceps, because the majority of the bruising runs down the medial aspect of the biceps, because that's where the bleeding tracks with a pec detachment. The classic signs you'll see is number one, the bruising. Number two, a loss of the muscle in the axillary fold. Thirdly, you'll see a bulging of the biceps, of the pec major. And then number four, you get this dropped nipple sign. So the alignment of the nipples in the horizontal plane is down. And this is a more chronic tear, and you can see the same sort of changes in a chronic tear. You often see this fascial cord over here, and some people think that's the tendon. It's really important you realize it's not. It's that fascial band, which is that link between the pectoralis fascia and the brachialis fascia, and that can be quite thick in some cases. And here you can see it on the left. Oops, I thought there'd be an arrow, but hopefully you can see my cursor. You can see that fascial band running down there, and you can see it on the right. It's on the right images, you can see that. So diagnosis, I like to use office ultrasound because it's immediate, and you can see the tendon attaching to the bone and the muscle, and this is a nice sternal component tendon. It's actually a post-op scan, and you can see it attached and rotating, so it's quite helpful and useful. In terms of MRI, you need to make sure you have the right protocol, and that's absolutely key. So the plane of the MRI scan images must be in the plane of the pec major, not in the plane of the patient and not in the plane of the shoulder. So in the plane of the pec major of the muscle tendon unit. You need to have the right surface coil, especially for larger patients, to get the right image clarity. And also what we like to have is axial T1s with a PD fat sat and coronal stirs and coronal T1s. These are the best for anatomy and also for showing the acute injuries where the injury is. And sagittal PD fat sats are very helpful to see those tendon detachments well. So if you have the right images, it's quite obvious. So you can see here's a tendon avulsion with the tendon curled up, lost its tension, and nothing attached to the humerus. And you can see here on the coronal sequences that nicely curled up tendon. You don't often see images as great as that. In a muscular tendinous tear, you very clearly see the tendon, and you can track it back to where the muscular tendinous tear is, and you can see the bleeding and the bruising. More medially, you can get muscle belly tears, and again, you'll see a very clear tendon tracking all the way underneath, and then the muscle belly tear, which is usually more superficial, is there, and you can see it in this case on the T1s. Often the patient as well, it's very clear that the defect is medial and there's muscle attached laterally. So, you know, surgery, when for surgery? So if you look most of the studies, and there's a few good studies that show with non-operative management, there's generally a 40 to 50% loss of adduction and flexion strength. So not everybody needs that particular strength, but there's a 40 to 50% loss of that particular strength. Patients can get cramping and a fatigue cramping, or the muscle fatigues with repetitive work. And then there's obviously the deformity, which people notice. But, you know, in terms of therapy, the result of non-operative rehab, the results are not bad. You know, they're still good, but in terms of general outcomes, comparing surgery with non-surgery, the results are generally better in terms of strength and return to function and pain relief for the right patients. I really want to highlight that this is not a cosmetic operation, and I certainly would not do it. If a patient comes for cosmetic reasons, I'm very fortunate we work with a plastic surgeon, and I'll then refer them to him for a cosmetic operation. But I'm not a cosmetic surgeon, and I'll make that very clear. One of the things I've come to learn, and very much the hard way, by operating on a lot of the wrong patients over the years to my own detriment, is which are the good patients and which are the bad patients. And on the left here, these are the good patients, the heavy manual workers who need that adduction and flexion strength that your pec will give you. And also in the middle, they're the professional athlete that needs that particular strength. Not all athletes need it, but those strength athletes, those are the ones. And the patients that have done the best with chronic repairs have been, you know, firefighters, police officers, laborers, builders, joiners. The bad patients are unfortunately, I'm sure you've seen them, the metrosexual crossfitters, your patients who are elderly crossfitters, don't appreciate their age and very much into their mirror muscles. And, you know, the one extreme would be your cross-fitting accountant. However, there is a gray zone in between these two types, and that's really where it starts to become a little bit difficult, because patients go on the internet and they learn what they need to tell you to get an operation. So once you decide you are going to operate, a little bit on the surgical technique, and this is the things we've learned over the years. You can see Ravi's name on that paper from 2010. And this was just publishing our footprint repair technique and some outcomes. And I think a lot of people do this now, which is to pass a number of locking and sliding sutures through in a footprint technique and tie that down. I do like, oh, sorry. I won't run that video, but I like the all suture anchors, which are ideal for cortical bone, and these come double loaded with suture tape, and the suture tape really is nice when repairing tendons and muscles. So I've moved to that over the last few years. So in terms of the procedure, a few tips for those of you who do it. I like to use a Tremano arm holder so you can position the arm where you want it. Prep the whole of the pec major. I used to, I also used to prep the other one for comparison in the past, but I've stopped doing that. The whole of the pec major, not just the area you're operating on. Then for the line of your incision, to make it more cosmetic, I used to go in the axilla, but we had a 10% wound infection rate. I've stopped that. I now go out of the axilla and just above, and nobody's complained. So to get that incision, put the arm across the chest so it's in the axillary fold, and then take it down towards the axilla, but not into the axilla in the axillary fold. Find the edges of the muscle. In acute cases, it's significantly easier. This is a chronic one. What you can find is there's that fascial fold or residual cord, and sometimes that can track you down to the humeral insertion, and then you find your pec major laterally, tag it, mobilize it. In chronic cases, mobilize it all the way to the sternum, superficially and deep, wash out for the medial and lateral pectoral neurovascular bundles. Then identify and expose the humerus, which is a long way down in a lot of these patients. Prep the footprint. We petal the cortex just to get some bleeding bone. Don't fully decorticate over about a centimeter area. Then this is an old video, so we've used some old Mitec anchors, and then you insert them in a footprint technique, so 2 lateral, 1 medial. And then do the suturing as we saw, so a combination of sliding and locking knots, so, you know, modified Whipple's technique. And then you can slide the tendon down onto the humerus. So this will be a locking and then a sliding on the other side. And generally, you know, the more sutures, the better. So you want a strong fixation so you can allow early mobilization, and then slide it down, and then always make sure after you've done the first one that you're absolutely flat on the humerus. That's really important. Oh, and the other thing is always the arm is positioned in neutral to slight external rotation when you do that repair. And flex the arm forward because it tends to drop back from its anatomical location when you're supine. And that's a final repair, and you can then move the arm and check the safe range of movement. Okay. So what happens in chronic cases? This unfortunate guy is a scaffolder and builder, and he fell off scaffolding and stopped himself from dying by grabbing both sides of scaffolding and tore both his pecs, and he came chronic. So on the one side, we could get a direct repair. On the other side, I've used tendo Achilles allograft again for many, many years. And the ideal is a nice sandwich technique, which has been published, or, you know, I do what I call a duvet technique, which is like stitching a duvet. The important thing is whichever technique you do, make sure that you can pull on the allograft to muscle attachment with your body weight. So I'll grab the tendon and lean back with my body weight, and there should be no movement between the muscle and the allograft, and then repair it and make sure you get that tension right, which is key. So in that position, as I said, in slight external rotation. So I'll let Doug go into the rehab. I won't go into that in any detail other than to say, as Doug will say, is it's a phase-based rehab, and it's modified for that particular patient and their particular functional demands. And Doug will go more on that. Post-op, ultrasound's really nice to assess the repair, and ideal. We did MR scan all our allograft to look at incorporation. It was very nice to see the incorporation. But what I want to highlight again for your patients is that you see that there's an area where you don't have muscle. So cosmetically, that will not look the same as that. I always say I'm replacing a muscle, a thick muscle, with a tendon. So it's for strength and pain relief, not for cosmesis. So this is our results, comparable with most of the literature, with 90% improvement in strength and function and pain relief, 80% improvement in cosmesis. We use the Skepsis scoring system. Then this is what I tell patients, and this is key, is that a direct repair has good and predictable results, but late allograft reconstructions, are really only reserved for the group that I said do well. And I highlight this to the bad patients, which do come late, and explain to them, at best, you may get 50% improvement in cramping pain and strength, and you probably will not be happy with the appearance. And you've got to document that very carefully. It's not a cosmetic operation. And the infection rates I put there have dropped significantly as a result of staying out of the axilla. And this is the slide I really want to put down to highlight for you. Can't highlight enough. Everything, the surgery is easy. It's just a technical procedure. The hard bit is choosing the right patients. Thank you very much.
Thank you, Prof. Such an important talk to all the upper limb surgeons worldwide, and it's clearly a complex problem to resolve in our practice, especially to meet the expectations of elite athletes, isn't it? Prof, just a quick question. Now, you have the luxury of having office-based ultrasound scan. Many of us don't. So do you have any preferred investigation?
For pec majors, well, the diagnosis is usually fairly obvious clinically. I think an MR scan is helpful, and I get that in every case. But if you don't have an MR scan that is a specific pec MR scan, it's very, very hard. And the majority, and I'm sure you've seen this report, say musculotendinous tear. And that leaves you in a difficult position, because clinically it looks like a tendon avulsion, but the reports always say muscular tenderness. So it's the only thing to do is try and train your radiologists, get them using a proper PEC protocol, and look at the images yourself. That's key. But don't rely wholly on the imaging. And I don't ultrasound all of them, but I definitely get MRI scans on all of them.
Right. Great. Another question, Prof, is I mean, your practice is mainly having tertiary referral as well, and we clearly seen in our last paper that we've got good results with patients coming to us almost 48 weeks since injury. Now, is there any cutoff you have in your practice where you would see like, look, it's worthwhile repairing or doing an allograft reconstruction?
Yeah, a good question. I don't think it's a specific time issue, really. Ideally, tendon avulsions are definitely much easier to find and repair acutely, and certainly within the first 6 weeks. And yeah, I'd say to younger surgeons is try and start off with the acute ones. The hematoma, when you find that hematoma, it helps. Chronic ones can be very difficult to work out what's going on. So, it can be a bit more difficult, but there isn't a particular time. It's really a particular patient that's more important. And what we found also is with the chronic ones, we always go in for query allograft reconstruction, but once you mobilize them sufficiently, probably more than 70%, I'm able to do a direct repair without an allograft. But the key is really choosing the right patients. I can't say that enough. And even I still get that wrong.
Sure. Another question is, what is your preferred? I mean, you've shown that all suture anchors, but over the period, do you think that's the best way of fixing this tendons?
In my opinion, yes. It's the easiest, and I don't like metal because you've then got artifact for post-op MRIs. So it makes post-op MRIs more difficult. And I'm sure Allan will talk about the pull-out strength of the all suture anchors. It's phenomenal, just as good, if not better. So yeah, I'm a total convert.
Excellent. Thanks, Prof. We'll come back to you regarding any further question. Matthew, you got a question? You mute.
Yeah, sorry. Can I ask a question then? You already answered it when I was your fellow, but it's quite nice for people who are starting off. Can you talk through about the degree of retraction that you see of the pec major tendon and how you look for it? Because that's quite a big point I learned from you. And when you're looking for it and how far you find it's actually retracted, because I was surprised when you went through it with me before.
Yeah, thanks, Matt. Just to highlight, Matt, please, when you feel ready, please start taking over the chronic tertiary referral ones. Thanks, Matt. I think it's like rotator cuffs. You want to mobilize extensively, so all the way over the top to the sternum and the clavicle, and all the way underneath bluntly to the sternum and the clavicle over the ribs. In some cases, there's an abdominal component, which you need to identify and repair. Majority of tendons that we saw there's a fascial cord, so they retract just a certain distance, just medial, centimeter or two medial to the axilla, and that's where you'll find them. Now, in some cases, I don't know if Matt was alluding to this, it's only the sternal head that's gone, and there's a tear, but you look inside and you can't find it. You need to go under the muscle and put your finger underneath, and you'll feel that scarred, rolled up tendon, and then you've got to mobilize it. It's not easy because it's a deep hole and it's underneath a big muscle. So a lot of good retraction and a lot of mobilization. As Matt knows, we probably spend the vast majority of time in these chronic cases just mobilizing things. The repair is the quick, easy bit, like rotator cuffs.
Thanks, Prof. Thanks, Matt, for that question. So our next speaker is Mr. Matthew Ricks. So Matt is a consultant upper limb surgeon at Wrightington with Prof. He's got a special interest in trauma and sports-related injuries upper limb. He's done his prestigious fellowship in Melbourne, Nice. He was also awarded Best Traveling Fellowship and Watanabe Arthroscopic Fellowship as well. Matt, being at the Center of Excellence, is widely published, and he's recently published his work on arthroscopic management of anterior glenoid bone loss. Matt is also closely associated with Wrightington FRCS upper limb course. He has keen interest in education and training fellows and other healthcare professionals. Over to you, Matt.
Thanks very much. Let me just share my screen. Lovely. So thank you, Ravi, and thank you for the invite to come and have a chat. And going after Len is a big shoes to fill and hard to follow. So and I'd love to hear his views at the end. Having been his fellow before, I know quite a few of the answers, but I've been given quite a controversial area to go through, which I know most shoulder surgeons can argue for hours over, is about the management of biceps pain in athletes. I remember when Ravi rang me to have a chat about this, I was like, oh, I'm not covering slap, okay? I don't want the slap debate, but I folded, so I've covered that in my topic as well. So we can have a debate at the end of that. But I'm one of the Wrightington upper limb consultants, and as Len said, you know, we're a family, and recently we've lost our founder, John Stanley. So that was a big loss to the department, but his legacy lives on with a huge number of us who are very keen in education and teaching. Len was one of the main reasons I went to Wrightington as a fellow, and the unit's the reason why I stayed, and they're a lovely bunch. So if any of you want to come and visit, please do. And SECEC in particular run a traveling fellowship, and we're one of their units as well. So let me see if this works. Good, lovely. So I'm going to cover a couple of areas with biceps. So we'll cover some anatomy, investigations in my practice, causes of pain, controversies of treatment, which is a discussion in itself, how I treat different biceps pathology, particularly focusing on athletes and young patients as well. We're quite fortunate where we work up in the Manchester area and Wigan as well, is we have a lot of sports teams, having come from the south as a trainee. Coming as a trainee from the south, they were actually quite starved for sports teams. They're all centered around London, but up in the Manchester area, we're absolutely spoiled with some fantastic athletes. And over in the Wigan area, we've got some brilliant rugby league teams as well. So a lot of active young patients to filter into our clinics. So biceps pathology in elite athletes. So there's a spectrum. So that's the key factor we're looking at in this presentation, is that it ranges from your tendinopathies to your slap tears to your associated injuries with your biceps path, being your cuff tears, and addressing instability elements of the biceps tendon. So the pathophysiology of biceps injury is commonly looked at in quite a bit of the literature. It's commonly done by repetitive overhead activities, falls onto outstretched arm, or traction injuries to the arm. You can see how any of those can occur during a game, but also during training and increased activities. And you can see how many times your baseball players pitch in a training episode to actually during the match as well. It's just ridiculous. And you can see how you can get repetitive injuries to the shoulder, in particular to the biceps, and how it can cause problems. And you've got your cricketers as well. And even from an early age, when they're bowling such large numbers during their training episodes, you can see how they can develop early pathology that we don't tend to see in the general population as prevalent as we do within the athlete population as well. In throwers, it's been shown that you can be the tightness of the posterior inferior glenohumeral ligament that shifts the glenohumeral contact point posterior-superiorly and can increase the shear force within the superior labrum. There'll be a lot of talk about the superior labrum as well, because it's commonly blamed for all of it. So the associated conditions when it comes to bicep pathology is key. So if I've got anyone with biceps pain, I'm always looking for associated pathology, because if you just zoom in on the biceps pathology, you can easily miss the associated pathology, or more so why they've got biceps pathology. If they've got an unstable biceps tendon, an associated subscap tear, scapular dyskinesia, all of these things are key to identify when looking for in your patient when you've got biceps pathology. So the long-headed biceps shoulder anatomy, you all know, the key factor is it's got a very poor blood supply. So you've got the labrum receiving blood from the capsule and the periosteal vessels, but not the underlying bone. And that the anterior superior labrum is the poorest blood supply of all of the labrum. And the biceps itself, as it enters in the joint over the bicipital groove, as it comes over the head of the humerus, attaching onto the supraglenoid and labral area, has no blood supply. So it has a very poor blood supply in that area. So you can see why, if you do have pathology, healing can be an issue, and how pathology can be an issue inside it. So there's been classifications based upon the long-headed biceps attachment, where they attaches on in the supraglenoid region and the labrum. And I think what this shows is there is a variety. It showed in this paper, this fantastic paper, 70% of patients were predominantly posterior, but it does show that there is a variance. There's some can be purely anterior, very small percent, only 5%, and how some are anterior posterior. But this will lend itself when we start talking about slap tears, when we start talking about function of the biceps as well, particularly within elite athletes of the shoulder. So when talking about the LHB in the shoulder, it's all about the stability and having a functional unit that allows obviously force to be transferred through it, and in particular with your throwers athletes, and to be able to do it repetitively. And that's the key factor when it comes to those athletes. So you obviously have the groove, the shape, the depth, the transverse humeral ligament that provides the stability element to it between the tuberosities. You need a stable biceps anchor, and that's one of the key factors we're going to talk about when it comes to the LHB, is we're talking about the pathology. And an intact rotator cuff, and key one is obviously the subscap as well. So that's whenever I've got a biceps pathology, I'm always considering whether there's a subscap injury when I'm examining them, but also when I'm looking at the imaging as well. So first thing to always address when talking about biceps pain is the slap tears, and there can be conferences all in slap tears and people all giving their different opinion, but I'll give you a quick key papers on the element of it and my idea, and it'd be great to hear Len's views on it. But obviously the main paper comes back from Snyder back in 1990 in the Journal of Arthroscopic and Related Surgery, a fantastic paper everyone should read. Anyone who does shoulder arthroscopy should know this. And it was a great series, 700 shoulders, 27 patients, and they described the slap tear, superior labrum, anterior posterior type tear, and identified it. His patient group that he identified, it was predominantly male, which if you look at all of these studies, it's mainly male patients, whether that's athletes, sports, biomechanics, all of these factors come into play. But in this paper, it's 23 males and 4 females. And it described the 4 distinct types, which we'll cover. And they described the patients were having pain, catching, popping, particularly worse in overhead activity. So not only your elite athletes, but if you have manual workers who work above shoulder height, your electricians, your plasterers, who we also see, these can have a very similar symptoms to what your overhead athletes can have, because they're constantly working above shoulder height, putting demand on the biceps area, and can get slap tears and patients. So coming on to slap tear 1, you've got the superior labrum, you get marked fraying. So you get the superior portion, which can give a degenerative appearance. You have the peripheral labral edge, which has still remained attached, and your biceps attachment is intact as well. So this is the image from Snyder's paper, and it's brilliant because what it shows is the degenerative frayed aspect to that superior glenoid. And you can see that. And you can imagine how if you were to debride it way, or to get your fluid from your arthroscope to go underneath, and using your probe, you should be able to see an intact anchor underneath it, and you should be able to see that the labrum is fixed underneath. And this is your type 1 tears. They're very amenable to do debridement if they're significantly symptomatic. Your slap tears type 2 is the big one they can debate about. So this is described as fraying, a degenerative appearance superiorly, but what you've got that's different to the type 1 is your superior labrum and biceps are detached from the glenoid. You've got the labral biceps anchor is unstable and comes away from the edge of the labrum. And this is a great image of it. And why this is a great image, because it shows that it was most likely traumatic. You've got bleeding underneath, you've most likely gone in early, and you can quite hopefully correlate with your clinical findings, your investigations, to hopefully point towards a traumatic type 2 slap injury. And so therefore, this is the one taken from Snyder's paper, and you can see that when he's probing it, you can see it comes away. You've got that space at the top there. You've got the traumatic appearance there. So as you come through the classifications, we've got our type 3, where you get your bucket handle tears that come down into the joint, with the central portion of the tear displaced down into the joint. You have the peripheral portion of the labrum can remain attached to the glenoid and biceps. And the reason we've said already is because the variation of the biceps insertion, particularly in the supraglenoid region, and it can also attach onto the labrum as well. So there are anatomical variants in your patient group, and then your biceps is intact with your type 3. This is a type 3 picture for Snyder's paper. You can see also the degenerative appearance of the labrum, but you've got that bucket tear that's gone down into the joint. And you can see how if that's flapping in the joint, how that can be painful. And you can imagine exactly the same within the bucket handle tears of the knee, and how your athletes would be struggling to perform with a bucket handle tear prolapsing down into the joint. Now, these are very difficult to reattach back on because they tend to be very degenerative. They tend to be quite frayed. And if they've been in the joint for a while, they'll be particularly trashed. So most people argue that when you do go in surgically, you review it, and sometimes it's not repairable. And what you end up doing is debriding and removing that tissue that's prolapsed down into the joint. So you come to your type 4s, you've got your bucket handle tears of the superior labrum, and the tear extends into the biceps tendon. So you've got your biceps tendon that's partially attached, and what you've got a portion of the labral flap, again, displacing down into the joint. This is obviously a bigger injury, and one of the factors that this is going to impact upon is your stability of your biceps anchor, because you've got a tear that's extending into it. And these are difficult to manage in your elite athlete population. Prevalence of these slap tears, by far it's the commonest is your type 2, so 41% compared to the other ones. And there's obviously been subclassifications of this over time. And I think one of the key factors to look at is you've obviously got the 4 original descriptions by Snyder, but the key factor is you've got a labral pathology here, and it can obviously progress anteriorly or posteriorly as well. So you've got your 5s where you're taking consideration the anterior inferior aspect, your Bankart lesion as it comes around to the front, or your reverse Bankart as it comes around to the posterior. And so you've got to take into consideration of the extension of you therefore destabilizing with this injury and tear further aspects of the labrum and getting an instability picture, and not just a biceps pain and biceps instability picture as well. There's also, if I come back to that, a great paper that shows that there is a significant inter and intra observer variability when classifying these. So some people may classify it as a 2, when in fact there's a lot more extension around to the front and it's more of a 5, or you're not looking at it properly and you're only doing an MRI and it looks like it's just a 7. And so it's quite interesting. There's a lot of variability there. So when it comes to biceps pathology, first as up with all of it is key with clinical examination. So you've got to look at scapular positioning and muscle atrophy. So I'm looking for any sign of cuff tears and associated pathology just with the biceps itself. I'm feeling the anterior bicipital groove and the length of the long head of the biceps, feeling for any tenderness within the groove and location of tenderness. I'm looking for range of movement in the shoulder, particularly pain. So not only the popping, the clicking sensation, and if you've got an athlete who's struggling to demonstrate their symptoms, get them to demonstrate the action that they do, get them to the bowl or throw a ball or do some sport action they're used to in their sport to demonstrate what causes their pain, so you get an idea of the mechanism that's causing their pain. Look for your cuff examination, all aspects of it, power, pain, and then do your instability test as well. Looking at your bicep specific tests, and there's a huge range of them. These are the ones that I perform, the Jurgensen, Speeds and O'Brien's tests. It'd be good to hear what Len does as well, because I know how meticulous Len is with his examination, having sat in with him as a fellow during his clinical examinations. There's also an 85% positive signs and apprehension test with these patients as well when you're examining them. So it comes to investigations for biceps pain. So this is again coming back to our spectrum, history, where there's a specific trauma, the number of throws that they do, whether they've increased the intensity of their training, whether they've had fluctuating episodes depending upon the season they're playing. So all of these are key factors to include in your history. And then the mechanism, if it's a contact or if they remember, or if they've got any video footage footage, because a lot of your elite athletes will have video footage if it is broadcast of the mechanism. Sometimes that's worth seeing as well. Examining the patient, I always get a plain film with their shoulder. We have an ultrasound availability quite often over in our Wrightington clinic. I know that Len has it over in his arm clinic as well for his one-stop clinic. But it's also a great way of having a look at the biceps. And when I was in France with Pascal, we played with the ultrasound all the time, particularly on the biceps, because it's easy to do. Don't be scared of the ultrasound. If you've got one in your department, particularly the NHS setup or your equivalent wherever you are, is get one and start playing one. I remember when I was Len's fellow, we used to use it on the cuff tears. So before we did a couple of the cuff tears, we used the ultrasound to have a look at the cuff tear and then compare it to our intraoperative findings. There's no reason why you can't do exactly the same with your biceps pathology as well. So play with the ultrasound if you've got it. So if you're investigating biceps pain, I think there's a very good point to have a look at ultrasound guided injections, either in the subacromial space or more importantly in the bicipital groove, to see if this can improve the pain as well. MRI imaging of the biceps is commonly done, and it's something that I commonly done, particularly with elite athletes or my manual workers who are adamant to go back to work as soon as they can, the self-employed ones in particular, looking for fluid around the biceps, indicative of your tendinopathy. An intact biceps is one factor, but also a subluxing biceps. I'm looking for associated tears, particularly of that subscap, and the location as I'm scrolling through my axials of that biceps tendon. And it's very easy to miss that you've got a biceps that isn't actually sitting in the groove anymore. It's subluxed out, you've got a partial or full thickness tear, and so you've got a potentially unstable biceps that could easily be causing a large proportion of the pain within the shoulder as well. When it comes to MRI imaging, it's a great paper down the corner by Boutin et al. In 2018, which covers the areas they look for when it's coming to slap tears. And obviously, you're looking at the superior portion of the labrum. You're looking for high signal intensity, particularly in the coronal imaging. They talk about multiple branching lines of high signal intensity in the superior labrum, giving you the suspicion of it as well. And sometimes the arthroscopic findings are the only way to actually confirm the diagnosis, but the MRI I find particularly helpful when trying to aid in your giving up a picture of what's going on with the pathology of your elite athletes or your manual workers. When it comes to the elephant in the room with bicipital pain, it's always about the treatment of type 2 slaps in athletes and throwing athletes as well. This is controversial. You get a lot of different opinions when it comes to it, and I'll hopefully give you quite a broad range of opinions here, and hopefully a cautious, because I am a cautious surgeon, and if I can avoid operating the patient, I will do, but if I have to operate, I will do as well. And I think you need a very skilled physiotherapy team when managing any shoulder pathology, and we're lucky to have them over at Wrightington, and Doug will go through his brilliant physio regime as well for it. There's evidence out there to show that slap repairs, particularly type 2s, do very badly in athletes. So how do type 2 slap repairs get on? There's some fantastic evidence out there, a lot of it by the Americans, mainly because of the baseball pitchers. They have a fantastic sport that predisposes itself to slap tears and injuries of the biceps in particular. We have some great sports over in the UK as well that do, ranging from your cricket, which obviously in India as well you have. And then when I was in Australia, we had Aussie rules football, and I was amazed by Aussie rules when I was out there. The amount of shoulder injuries that you get are phenomenal. When I went out there before, I wasn't fully convinced on the contact nature of the sport, but when I went out and I worked out there and saw it, I was amazed by the physicality and the contact aspect of it. And you can see how they get such horrendous shoulder injuries from it. So this was a fantastic paper by Neri in 2010, looking at type 2 slap repairs. And I think the key take-home message from this is your return to pre-injury level. And this is back in 2010. We'd known about it since 1990, and this shows that in elite overhead athletes that you can, in just under half of the patient group that you operate on, will not return to the pre-injury level. And I think this is a very important point to consider when repairing slap 2 tears in your overhead athletes, and that it's particularly correlated with your partial thickness rotator cuff tear. So be aware to look for your subscap tear. And this is another take-home message from this paper, that if you have a subscap tear, your outcome can be worse than someone who doesn't have it. And so it's key to highlight to your athletes if they do it. So why do type 2 slap tears do so badly? If we identify and operate on them early, then why do they do so badly? And the big question is whether movement at the top of the labral biceps anchor junction is a beneficial action when it comes to these athletes. There's a fantastic paper by Lesniak in the American Journal of Sports Medicine, which highlighted that 48% of asymptomatic pitchers had a slap lesion, type 2. And so that's an amazingly high level when, if you come back, not a huge amount of the population actually had it. When Snyder's original paper had 700 shoulders with only, 28 patients with a slap lesion in. So that's a huge number. So why are these patients having such high numbers of slap tears when a majority of them, just under half are asymptomatic? The question is are your type 2 slap tears actually a normal variance? Is there an increased movement? And this isn't my theory. This is widely discussed throughout the shoulder community. And is there increased movement of the superior labrum and the biceps anchor that actually allows a beneficial adaptation to the shoulder, and which is why these people are elite athletes? Is this why someone can bowl faster than me, that they're able to throw an American football that distance, or they can spin bowl it to that degree and that speed? Is it because they not only have the training, the skill set, but they have the biological variance that allows them to get that little bit of extra edge, that little bit of extra velocity, and allows that greater labral mobility? And if that's contributed to their movement, then us slapping a couple of anchors down and pulling it down and creating a lovely tight complex at the top of the shoulder may take away what made them great before. And so that's an interesting area, which is what people can debate about till the cows come home. So the question is, what do we do to try and work out what's normal, what's pathological, particularly with our type 2s? And a key factor of that is pain. And so you need to try and assess pain, whether the mobility and instability element of that labrum and biceps complex is causing their pain and leads to their loss of performance in particular. So what about young patients with slap repairs? There's good evidence out there coming down the line, 2013 by Venture, showing that you can get good results clinically and statistically significant improvement in shoulder outcomes with type 2 slap repair. But again, look at the failure rate. Most surgery and shoulder surgery or surgery in general, we won't be happy with these complication rates. 40% had failure, 30% revision rate, that's high. But you do have I say demanding, you have a population that want to get back to such a high level, and it's such marginal gains at that level that these have high revision rates with it. And one of the key factors from this paper, which I think is a great take-home message, is the age. Creeping up to the 40 mark. Myself, I think I'm very young, and I am very young, but according to them, I would probably most likely have a high chance of failure. And they use this 36 years age, and I've adopted that into my practice, because I think over the age of 40, particularly, even if they're in the elite athlete group, you need to start considering whether you should be doing primary slap repairs and whether you should be considering a tenodesis, and I'll cover that as well. So one of the great things, which is an answer that we can give you, what happens when your type 2 failure fails? Tenodesis. So that's a great option. It's been shown out there in the literature, and I think it's a safe option rather than a revision procedure, and it's been shown with an 80% return to active duty and sports rate, which is a good number. For orthopedics, that's a good number. And that tenodesis is a predictable and safe and effective treatment for your failed slap repairs. And there's a great paper by McCormick back in the American Journal of Sports and Medicine in 2014. So coming back, how do I investigate my biceps pain in my athletes? So history, examination, I've covered pain films. I always tend to get with shoulder pain, and especially with athletes as well. MRI scan with contrast. And then if I'm unsure of the cause of the pain, or it's not particularly clear, I can do an ultrasound guided injection, as much diagnostic as it is therapeutic. And we can do that in clinic in some situations, but sometimes my radiology colleagues are fantastic with it. And I work with great colleagues over in Wrightington as well. And one of the factors that everyone can talk about is about resting from sports physio, which I'll let Doug to cover in more detail. And so what conservative management there for biceps pathology, I'll let Doug go again in that in more detail, but majority of biceps pain, conservative management is my first day of treatment. See if it settles down. Stop throwing so often, decreasing the number of repetitions you're putting through the shoulder, a rest from sport for a period of time, because this may filter out a portion of your patients who don't need any intervention surgically. And in some situations, an ultrasound guided injection can improve their pain, and a rehab focus, which Doug will cover as well. So how do I treat my tendinopathy? I've covered that as well. So hopefully resting. Rarely do I end up needing doing tenodesis. I can tell you rarely do I do a tenotomy in a young age group patient population. But the rehab, which Doug will cover as well. So majority of my tendinopathies are conservative based, a rest from a sport for a period of time, ultrasound guided injections, topical therapy, ice cold therapy, or usual things for conservative management. So how do I manage my slap tears? That's the question. I've already mentioned in your degenerative ones, if you're in there, you can find debridement of it can have some improvement of pain. But the key factor with your bucket handle tears that are down it is I do think you have to consider excising them. I do find it's very difficult in these degenerative worn labrums to reattach them back on. And so debridement may be the only option for them. Now you're coming to your slap to tear management. You know, I've used the 40 mark because I still fall within the young bracket, which is fantastic. But there's also that great paper that shows the 36 year mark. And I think it is a big decision in the discussion you have with your patient, whether you're going to do a fixation or a tenotomy, particularly if they're below the age of 40. I think majority of surgeons will consider arthroscopic debridement plus anchor fixation of your labrum, and then greater than 40 will consider a tenodesis, and then rarely will I consider a tenotomy in my patient population. So how do I make the assessment coming back to whether it's pathological or whether it's a normal variance? So I do this on a number of factors: my history, my examination, injections, imaging, where they failed to respond to conservative management, and intraoperative findings. That fantastic image of Snyder showing that picture of the traumatic labral injury for the type 2 they had there. And sometimes intraoperatively you can get an idea or inkling that it's more of a chronic, not chronic, but a variance that you've got there. So how do I fix my slap tear? It's a key factor with all shoulder arthroscopy is good visualization, correct cannula position, good fluid flow as you're going through. So you debride your degenerative tissue and the glenoid rim itself. You're preparing the glenoid, you shave. I brush with a burr, try not decorticate too much so it doesn't affect my pull-out strength of my anchors. And then you do a simple mattress suture repair to bring it down. I do a knotless anchor just to try and decrease the amount of tissue, particularly suture tissue that's in the joint. So coming back, you know, we can debate for a long time about slap type 2. It'd be great to hear Len's views on the matter. But the key factor when it comes to biceps pain is that although you have a broad spectrum for management, it is tailored to your athlete, the sport, and their age and their functional demand they want to get back to. You need to work through the history, how it occurs, how much they've been putting through their shoulder, what sports activities, how they could have injured it, and examining them thoroughly. Investigations are vital when doing this, and I always investigate early. Physio is key throughout all aspects of this, conservative, surgical, whichever route you go down. You need a good physio team that you communicate with, who can come back to you at any point to say, this athlete, this patient, this manual worker is really struggling. You know, they're not where I'd expect them to be. You know, they're really struggling with work or whatever, and then you just get them back to see, and then you can always change and go down a different pathway if appropriate. And always discuss with your patients the risks of surgery. Now, the key factor with your athletes is you can't tell them, I'll get you back to playing high-level sports 100%, because there's not with any surgery 100%. And it's shown within the literature that even slap 2 type repairs, even if you do the most beautiful anchor repair in the world, if it was a normal variance, a lifting up, and it wasn't an acute traumatic one, you could take away what made them great before. And that's a big factor to take in consideration. So when you're talking to your athletes, you need to make sure that they're aware that this surgery for the biceps is a big surgery to go through and carries quite a big risk for them as well. Thanks very much. That's me waffling on.
Thanks, Matthew. It's very elaborate talk on a very complex problem we see in our practice. Matt, just a quick thing. You showed a picture of Freddie Flintoff. I know Freddie well because his son plays cricket with my son in a county cricket. Now, if I'll take you back to 2005. 6 months before Ashes series, and Freddie comes to you with a slap to tear. How would you manage him, and what would you tell him?
I am a big fan of Freddie, hence why he's on there, and I haven't seen him or treated him, so I can't claim any glory to that. Great point. MDT is my first port of call to get support for that with V1. It's a big discussion to have. You know, you're looking at him, you're looking at what he's been going through to build up to that, and you've got the problem that if it's affecting his function, then you've got the problem of either him resting for a period of time, which wouldn't be an option leading up to the Ashes.
Yeah.
He's going to have a lot of demand going in to try and get back to the level that he's performing at. And the difficult aspect is the fixation. If you go in, there's recovery from the surgery itself, but you may be giving him a chance of getting back to a good functional level, but you're exposing him the risk of the surgery itself. That is the golden question, which is difficult.
Yeah, no, I think I agree with you, because the player of his caliber, he want to get back. He spent his whole life, preparing for that. And what do you do? It's a tricky thing.
And that comes back to the point being that you get to that level not just from putting the hours in. You get from being naturally talented is one factor, and there must be an element of a physiological advantage that these people have. Certain sports, you've got the increased Baton score, the increased movement of your joints, increased musculature of certain patients. But some people can just do things that I would never be able to do, and he's one of them. That's a good one.
Prof got his hand up. I would like to hear his view on that as well.
No, sorry, I didn't put my hand up to give my view. I put my hand up to ask Matt questions. But my view is, I think very much like Matt highlighted in his talk, is don't treat the slap tear, treat the patient. And there's multiple factors involved in treating the patient. And as Matt showed in his talk, one of the studies, pretty much all cricketers, in my experience, by the time they get to 28, have slap tears, either asymptomatic or symptomatic. And many cricketers that I've seen have got slap tears and can cope. So actually at the highest level, they can cope with slap tears. So don't treat the slap tear, treat the patient. But so my question for Matt was, I'm sorry if I missed it, but any technical tips you could share with people on slap repair and biceps tenodesis in athletes? Anything you could share with us on technical tips in repairing them?
Yeah, so biceps tenodesis is an interesting point. I think it's a very good operation to do in some patient group. I think when I worked with Pascal, he claimed he did the first biceps tenodesis and wrote it up, which was quite interesting. And his technique for it, the European approach, does vary from the UK. But I haven't been your fellow as well before, Len. I know there's a whole range of doing biceps tenodesis. And I think key factor is what you're addressing when it comes to the tenodesis. Whereas in Australia, I got a lot of experience of subpectoral, which I thought was a great technique to do in some patient populations, particularly the ones where you need a strong pull-out strength. And when I was in France, we did a lot of proximal tenodesis, just from the subacromial space, identifying the biceps, anchoring it down, and then releasing. And I think one of the key factors that taught me was about getting the tension right in your biceps tenodesis. And I think that's the big thing whenever I talk about tenodesis, it's about tension. If you release the biceps first and then attach it, it can be difficult to get your tension right. If you're doing a subpectoral tenodesis, you have to make sure you're getting your tension and your length right, because if you do a beautiful tenodesis, but you get the length or tension right, patients won't thank you. They can have a functional impairment, but more so they can have pain, particularly if you stretch it up, they can have some biceps pain. So from a tenodesis point of view, I think majority of tenodesis I will perform in the subacromial space area. However, that will still leave your biceps tendon within the groove. So if I'm concerned that they're going to have some biceps pain, or if they've had pain within that groove, then I have a very low threshold to do a subpectoral tenodesis, because then you could take out that pain generating element that's in there. When it comes to the anchor repair, I think I do exactly what you taught me, Len, to do, which is your knotless anchors superiorly, getting a good fixation there and making sure you have good visualization, because you taught me brilliantly that it's all about visualization with shoulder arthroscopy. And that's the key factor in having good flow, because you can be in there a fair amount of time doing the repair and you have to be able to see it properly. But biceps tenodesis, I think, is a great question. It'll be good to hear, Ravi and Len, what your preferences are for tenodesis in your athletes. Are you a subpectoral person, or do you go above?
Yeah, means Matt, we had this luxury of getting trained with Len, so we do what he did, and we believe that it worked, and it does work. But my preference is mainly subpectoral tenodesis. I struggle. I don't think I've acquired the skills like Prof has, but I do a quick arthroscopy, tenotomy, and then do subpectoral tenodesis.
There was a great paper I read a couple of years ago about the close proximity of structures when doing a subpectoral tenodesis. And there's only a couple of papers that have ever scared me. And one was the Greg Bain, when I do my distal biceps attachment. He did a paper on the proximity of important structures when doing your drill hole, and it scares the hell out of me. But I do think you have to see the bone, and you have to get down and get proper exposure. Otherwise, you could easily damage something. Len?
Yeah, I completely agree with what you'd said, in that I don't think, and if you look at the literature, it doesn't matter whether you do it intra-articular, in the groove, subdeltoid, suprapec, subpec. The results statistically are much the same. I think what you highlighted is really important about getting the tension right. That's absolutely key. From a technical point of view. And then exactly what you said is go below the disease. So where, like you said, if you think the groove is affected, then go below the disease. And if it's a slap tear, you below the disease being intra-articular. So, and if you look statistically at the literature, the results are much the same.
Yeah, I mean, clearly it's a debatable topic, isn't it? Now, people would argue whether do I just do a tenotomy and, create that iatrogenic papaya, or do tenodesis. And I think, my practice, I do as Prof has taught us, that choose the patient rather than, if an appropriate patient with appropriate requirement, can you meet their expectations? And, depending on that, I choose my treatment options. Great. So, we'll move on to Doug. Doug is a chartered physiotherapist, having worked in professional sports over 2 decades in partnership with Sale Shark, London Wasps, and senior England team. These are rugby teams, and he's owner of Altius Healthcare, which was established in 2015. Means Doug has gone through a rough time, and he recovered well from his brain tumor surgery. Well done to you, Doug. He is director of the Altius Healthcare and works as a high performance manager for many championship football team, as well as he manages the medical services for Honda UK and Mercedes AMG GT racing car team. He thrives to establish and run a healthcare services to cater for elite athletes. He's a keen mountaineer, and he has climbed extensively in the Alps, including summit in Matterhorn for charity in 2018. Over to you, Doug.
Brilliant. Thanks, Ravi. Thanks very much for, again, inviting me here. Happy Mother's Day for all the mums that are watching. Just going to get my presentation. So hopefully everyone can see that. So I've been asked to talk about just my experience really over the years of managing athletes, and yeah, the key things which I've learned. Athletes don't tend to do as they're told. They do all the things that are going to cause injury, are going to break the soft tissues that you guys diligently spend time repairing. Len and I collaborated on a study years ago where we looked at mechanisms of injury. Normally, soft tissue tears in rugby, they have a mechanism, and we looked arthroscopically after the videos, and the position their arms were in depended on a lot of the time what soft tissue structures they injured. And this particular athlete, who's just taking a rest, doing a little bit of mindfulness there before she attempts the next move. You can see her arms are in, above head elevation, and they're posterior to the axillary line, and that tends to be where the repair is most at risk. And that's the area where, shocked to see that over half of these kind of overhead athletes have a failure when they return to sport. So, we strive to try and improve that. Yeah, as I say, I've worked in motorsport. I worked for Red Bull, and I've worked in professional rugby and seen lots and lots of collisions. Very, very fortunate to see lots and lots of people with lots of bad injuries, and spent lots of time with lots of different surgeons. So had lots of exposure, getting it wrong and getting it right. That's what's so nice when you hear Len speak. It's really refreshing that he's kind of got an open view and thinks about the things he gets right as well as the things he gets wrong. So what I want to do is basically introduce my learning, and it's all about what they can do. If they don't use what they've got, then they tend to lose it, and that puts them at risk. I think as rehab professionals, we have to respect the kinetic chain. We get very bogged down in the anatomy of the shoulder. And as we all know, 80% of the stability of the glenohumeral joint comes from the muscles that surround it. It's free floating, and it takes 18 muscles to all co-contract together to keep the ball in the socket. So if we just repair the bits that are torn, they're likely to tear again, unless we look at the rest of the body and how it works. If we, of the patients who I've seen who've had physio elsewhere and re-ruptured, when you question them in clinic in their first session, they talk about fear, they talk about pain, and they talk about not wanting to load. And they're normally the things that contribute to re-injury. And a large proportion of my work nowadays is about talking and reassuring and giving people confidence. I think that's a big thing when you have a traumatic injury like some of these. And if in rehab, people who want to return to sport at the highest level, if we're not replicating the game, if we don't understand the specific mechanics of the injury and replicate them in the gym progressively, then the likelihood is that we don't condition them to return and therefore re-injure. The deal, I'm going to be 15 minutes because my son is 8 today, and he said, you can do this talk, but you must talk to everyone about me in the presentation, and you must only be 15 minutes. So happy birthday, Cameron. Just a short clip. So this is Andrew Sheridan. Yeah. 2005. We're getting him ready for the World Cup. He's British Lion. Sorry about the quality of the video. But we learned a lot from him, Len and I. His father was a criminal barrister and his mother was a neurosurgeon. And so, he's got quite a lot of brains as well as brawn. And he basically ignored everything that Len and I said and did his own thing. And we realized that actually he was right, we were wrong. He understood from a very early point that if he maintained the strength of his body and protected the injured area, then he'd get better quicker. And then when he returned, he would be less likely to injure. Yeah. So what we do is we understand what the mechanism is, and then we progressively expose the patient to that mechanism over a period of time. And they return when they can complete the movement right equals left. But we must. Generally, people tear a bicep or a pec under fatigue, and they tend to do it when they're in a weak and vulnerable position they're not used to. So the trick is to expose them to a vast majority of different positions that makes them feel weak and vulnerable in the gym. And if they can do them movements safely when they're tired, then they'll not tear when they're in the game situation. I'd come into the gym and I'd see Andrew doing things like this. This is 2 weeks post-op. He'd be out of his sling, and he understood that the average scrum lasted 8 seconds, that normally it was 5 times body weight on his neck. And he felt that he tore his shoulder when the scrum collapsed, and he felt that his neck and his back weren't strong enough. And it was unusual that for his ability to move, he was weak in certain positions. So for the first 6 weeks, we didn't really do anything with his shoulder and just focused on his neck and upper back. But when do you return someone to sport? And how do you make a sensible decision about whether they're fit? And again, what you've got to do is you've got to put that arm in a weak and vulnerable position progressively. Break down the movement. So all the players, we felt that a big part of their problem was when their shoulder became injured, it was because their trunk and upper back were compromised. So we spent a lot of time breaking down the movements that caused potential injury at their shoulder, and a vast majority of it was keeping their back stable with their hips. Very simple exercises in an area that doesn't load their chest, but the minute you take their stability away, they start to really struggle. And they would normally do that with 20, 25 kilos, take his base of support away on an unstable surface, and he finds things really, really difficult. My focus in the first 6 weeks is undoing what the mobilization period has done. I tend to think and educate the patients about this. Patients love a syndrome, so normally this is what the sling does. It does a lot of good things, but it also does this as well, which sets patients up for impingement. This is a professional footballer that Len sent to me. It's 3 weeks post-op, having had a pec repair. We took him out of the sling, and he's got good range of movement to 90 degrees. My focus is on managing his scapular rhythm, scapulohumeral rhythm, because if we don't work on that, his pec will repair. That's a given, because we're not going to do anything to load it, but he'll get secondary problems which will slow down his rehab later on. You can see he's already developed dyskinesis in flexion. He has no dyskinesis in abduction, so I'm not going to work on that really. I'm just going to focus on flexion and teaching him to try and get his scapula back. He's got latissimus dorsi inhibition there, as he's got inferior angle winging, and that sets him up for impingement. And if we don't address that early, then he'll get pain later on in the anterior part of his shoulder, and he'll be sat in a room with a surgeon going, your repair hasn't worked. And it's just, he's got poor movement patterns that haven't been addressed early on. So my goal for the first 6 weeks is to get his right shoulder looking like his left at 90 degrees. Len and I also collaborated on a bit of a paper to try and define what we can do when and how we progress. And we simplified it into zones of movement. And in zone A, we don't really test the repair, providing we've got good scapular control. So in the first 6 weeks, I'm going to look at loading in zone A, which is parallel to the mid-axillary line and not above 90 degrees. And my building blocks, as long as I've got good strength in zone A, I can then progress to B and then finally A. When I first met Len, him and I spent many late nights talking about timeframes and protocols. And over 20 years, I've chucked most of them in the bin and focus on the patient, how they present each day, and progress them as symptoms and function allow, rather than timeframes. So this is the chap that I'm seeing at the moment, and we're just practicing movement. And we're videoing him, and we're trying to get right equals left movement. We're in zone A here, we're not 90 degrees, and we're not going past the mid-axillary line, so we're all safe. And at 3 weeks, we start to do things like that. Closed chain exercise is the biggest thing that through EMG studies stimulates the rotator cuff to work. So spend a large amount of time in the early stages doing trunk activity with my hands fixed on the table. And we do a variety of exercises like that. I can spend in the first 6 weeks probably 70% of my time not talking about the shoulder, but focused on the trunk and pelvis. The majority of tears probably occur when you look back at the video where the arm moves independently, separately to the trunk. And that creates too much torsion, too much stress at the shoulder, which we think is what causes the tear. So understanding the kinetic chain, how the trunk and the arm work together. Often we see the opposite hip has weakness down that side. So a lot of the time in the first 6 weeks, first 3 months, what we do is we focus on the contralateral lower limb. I know it sounds a bit out there, but when we assess using isokinetics or handheld dynamometry consistently, and we probably should do a paper on this, they've got weakness in their lower limb, hip, and poor stability. And we think that's what causes increased stress and strains around the shoulder girdle. 6 weeks, I've found, is the watershed time when we can start to load the repair. The people who I see in clinic who haven't seen one of us at Altius and their surgery has failed, it's because at 6 weeks and after 6 weeks, they haven't spent enough time loading it. These are just some clips of the type of things that I'll do. All small movements, all focused on getting out of zone A and into zone B. Lots and lots of communication, lots of mirrors, lots of palpation, not very much load, but focusing on trying to get the lats working, trying to get the glenohumeral joint gliding on the rib cage. He's a professional cyclist, and those big marks are what a lot of them tend to have because they fall off a lot. Same again. We must not be afraid to load the repair. And in zone A, we can do this at 3 weeks. We respect pain and symptoms, but if they're pain-free, I've got no problem with starting to load the repair. And again, if we don't, that's when we get into problems. Really important to baseline an individual's strength in zone A, and they must be right equals left before they progress to zone B. These are really excellent devices now where you get wireless, handheld, dynamometry, which gives you, obviously that's doing that in a short lever abduction position, but you can do it in internal, external rotation, abduction, and you can do it in various degrees of range of movement as well. The repair starts to get loaded from zone A to zone B, and we can measure using a goniometer how much range they've got, when they start to feel tight, and we can improve that from 6 weeks. When you talk to people who have had a re-tear, a lot of the time it's because they haven't been stretching after 6 weeks to repair, and they also haven't had a huge amount of manual therapy at 6 weeks into the repair. So we believe that we can manually change the soft tissues with our hands, with Grafton tools, and the people who don't tend to do well or pick up soreness and stiffness are the ones that haven't had manual therapy during the rehab process. So we know that people are at risk in outer range positions. So again, we want to find out the ability to push and pull in those positions before we start returning them to controlled exercises with other people, multi-directional forces, slippery surfaces. So we can gain a lot of comfort with information that we get now in elite sport. And we've also hopefully usually got the other side to compare against. I've started to talk more and more about the mind and people's attitudes. And, you know, I used to think it was very wasn't very comfortable talking about the way people feel. But actually, particularly with the PEC, I've found it's really important at a very early stage to talk about the trauma that they've gone through and the injury, and to talk about the fear of re-injuring and the fear they associate with going back to what they did when they injured it. And constantly making reference to that has actually helped a lot of people, I've found, and they're reticent to talk about it. But if you don't address it, people will shy away from that movement pattern. And often that is the biggest part of the rehab, rather than any specific magic exercise. It's more about addressing their attitude towards the injury. The other thing I find is really useful to talk about in their rehab is their attitude towards pain. And Matt talked about it earlier as well, but you know, athletes do things to aggravate their body, and they get an overload response, and athletes can do things that the general public can't do. Unfortunately, one of the associated effects of that is pain and overuse. And you know, for us to generate the type of strength and loads that they require to return in 4 to 6 months from a major traumatic injury plus surgery plus a period of immobilization, they're probably going to need some medication and control of pain relief. Because if we're not controlling their pain well in rehab, then we're not going to load them effectively, and therefore we're not going to generate the strength we need to protect themselves. So athletes vary wildly. Some love taking medication, others don't take it at all. So it's really important to be guided by their symptoms, but also accept that there's going to be a period of discomfort during this process. It's inevitable, isn't it, that you know, they're creating 5G, 5 times body weight, and their arm's going to be past the mid-axillary line in a lot of occasions. So we must, in the rehab process, and I can't overemphasize this enough, get them in vulnerable positions and recreate the loads that are caused in the sport. Matt talked about this as well, but sometimes it's very, very important to expose them, but also it's very important to allow the natural healing process and talk to the player about pacing and technique. And a lot of the time, rest is as important as exercise, and recovering to go again. And normally what we would look at is a day on, day off for the first 6 weeks. So we'd load the shoulder Monday, Wednesday, Friday, and then we'd switch at 6 weeks to loading it 2 days, and then a day off, loading it 2 days, and then 2 days off. And then gradually, but 3 to 4 months, we'd replicate the ideal week, which is a heavy load, i.e. game stimulus once a week, followed by 3 full days of load, including contact collisions, followed by a day off. And it's, you know, understanding what the ideal week would look like in an athlete is an important discussion, because that guides how we rehabilitate them at the end stage. If they're not repeat aggravating and loading the shoulder 3 days in a row, then they're not going to tolerate the working week. I thought I'd take this opportunity to thank the professor publicly. I haven't really done this yet. He did a large ligament replacement on my shoulder a couple of years ago, which enabled me to climb the Matterhorn. So I wanted to thank him very much, because as much as I dislike surgery and surgeons, sometimes you have to say, you know, you need to get it fixed. So he was right, I was wrong. I wasn't going to rehab through that. And yeah, finally, happy Mother's Day. Thank you very much. Any questions?
Thanks, Doug. Such an extensive talk on a very important issue. And as a surgeon, we clearly understand and acknowledge the role played by expert physiotherapists, and especially getting patients back to what they do. And if it's an elite athlete, then getting back to their pre-injury level. And I think, I'm sure Matt and the Prof will agree with me that our contribution as a surgeon is very minimal compared to what you guys do to get them back to what they want. Just a quick question, Doug. When you see the patient or a sports person not recovering the way you want and the surgeon is expected, do you have any role for doing kind of some sort of neurophysiological study or doing an EMG to see why things are not progressing the way you want?
I don't have those sort of facilities. My facilities are a gym and a treatment room, you know, and a video camera. We use the consultants and the radiologists to help us with anything like that. But a lot of the time, really, we don't tend to, the athlete will go back for their 6-week review. They might go back at 3 months, but very rarely in elite sport do we need EMG studies and things like that post-op.
Thanks. Now, one more question is, when you see athletes with biceps related problems or pec major, and when we talk about getting them back to a pre-injury level of sports, now consider somebody is coming with their kind of an adolescent age where they want to get into the premiership team or, you know, first team, and they want to enhance their performance. Do you see that happening over the period? I mean, we talked about pre-injury level, but if they have to improve their level of performance to get into the national or national team, do you see that happen over a period?
Yeah, I mean, they're constantly trying to improve their performance. We tend to see, you know, athletes from people who are in the latter stages of their career trying to maintain first team position, and also people who've fallen out of favour for whatever reason. Sport is a cruel profession sometimes, and often we see injury as an opportunity. You know, in the highest level in sports medicine, usually they've become injured either to do with a lack of range of movement, a lack of fitness, a lack of strength, as well as bad luck. So we always say that, you know, work on your range of movement, work on your mobility, work on your strength, because this may be the secret to improving your performance. So they're very closely related. Yeah.
Matt, do you have any questions for Doug?
Doug, brilliant. I learned lots. That's fantastic. Just one question. Do you do any water-based therapy at all, or pool-based with any of your athletes at all? Do you think there's any benefit from any of these non-swimmers to get in the pool and do any activities? Just out of interest?
Yeah, as soon as the wound is healed, we do. I've actually got loads of videos, which I haven't put in, about hydro. And we do a load of strength and conditioning. The problem with running people on the treadmill early is there's a lot of impact that goes through the shoulder joint. So all our running based work we do in water. And at Stoke Football Club, where I am at the moment, they've got a great hydro pool with a flume that they work against. But even if they haven't got that, a lot of the, we haven't done much hydro this year, obviously, because none of the pools are available. But generally speaking, chest height water is a fantastic way of getting trunk control and maintaining some whole body conditioning without putting the associated ground reaction force through the shoulder. And then once we're happy, and at 6 weeks, you know, we've had sign off, we do a lot of proprioceptive neuromuscular facilitation. So that's safe movement through functional ranges up and past the repair. And we use the resistance of the water to replicate movements. So yeah, I'm gutted. I've got loads of video about hydro. I should have put them in. But yeah, no, that's a big part of my practice, and we do a lot of that. But obviously, you know, I don't tend to do it when their wound isn't safe. So I let the wound settle down. I don't really put them in the water when they've got dressings, I just let it all settle down, and at sort of week 3, we would start, because we're doing movements that actually stretch some of the wounds, and I've had a couple of people where their wounds have opened in water. So as long as their wound is great, yeah, they're in the water 2-3 times a week.
Prof, you got any question for Doug?
Yeah, Doug, thank you very much. It's very kind of you, but to be honest with you, as Doug knows, I learned a lot from Doug and other physios and over the years, and also a lot from Doug. We did research together, a number of studies. In fact, Doug did his PhD with some input from me. That was great times. So thank you. But so what I want to ask, in terms of return to play, what are your thoughts of when a player returns to play, and what's your experience? I know you've used lots of objective tests in the past. What's your thoughts on the role of specific objective tests in returning to sport?
Well, essentially, they need to have full mobility. I mean, Len and I have worked with people who have had both their shoulders operated on at the same time. I remember Andy Tuolangi turned up outside my house and said, I live alone, so I've decided I'm moving in with you. And he had both arms in a sling. So my wife was delighted. Luckily, we didn't have any children at that time. But usually they have a good side. So we try and return their mobility and strength through range before we do anything else. And we look at a couple of things, 3 rep max in various positions. So the maximum you can lift 3 times, and then we half that and then look at their endurance capacity. So the number of repetitions they can do with half that weight. And you can do that in any position. But return to play, you know, if it's a biceps, we worry about up here. If it's a pec, we worry about out there. So we would do very simple tests like that with as heavy as you can lift. And then we use isokinetics as well to decide in these outer range positions how much they can lift concentrically and eccentrically. And then the most important thing is about exposing them to what they injured in the past. So if they tore their chest tackling, then you know they're unable to return to play until they can replicate the game. So you know sometimes a flanker, for example, needs to tackle 35 times in a game. We've seen if you're a front row forward, you have to have your arm out in extended position and twist through. The average scrum creates 5 times body pressure, and you normally do 8 to 10 scrums in a game. So we would gradually expose them to that in training outside of the gym. And only when they've got good technique, good power, and no reaction over a period of weeks would we then expose them to controlled contact training.
Great. Thanks, Doug. Really appreciate your input in this. I'm mindful about time. I'm just going to quickly ask Allan Stanton. Allan is representing Stryker here. He's a territory sales manager, and he deals with the sports medicine and arthroscopic portfolio. Allan, do you want to share your slide?
Thanks, Ravi. Yes, I'll do that right now. Great, thanks for that, Ravi. I'll just go into presenter mode. There we go. I hope you can see that. Yeah, it's just a quick overview of the ICONIX All Suture anchor platform, in particular looking at the needles. So I'll just move along. So yeah, just looking at the timeline and how these anchors came about. So basically, they started in 2012, and we launched our 2.3 and our 1.4 options. We've moved along steadily to be the first company to produce a tieable tape for this particular anchor. And then the anchors in question, the ICONIX with needles. So coming along at a 1.4 and a 2.3 option with needles, with a tieable tape option and a normal number 2 suture for both. And then more recently, we were proud to produce and release our ICONIX Speed, which is a self-punching all suture anchor. So we have an option of 4 different constructs there, including tieable tape, a hybrid between quite a narrow type of tape and a wider tape, and normal suture, and then a triple loaded option as well. Good. So just having a look at these little anchors and sort of how they work. So basically, as you can see on the picture on the left, there's a before and after. And on the left, you'll notice that the anchor is not engaged. So that is how the anchor goes into the joints. And you'll have a polyester sheath, which has got targeted compression zones, which will bunch up and basically create that fixation underneath your cortical layer. So these anchors rely on cortical fixation for their pull-out strength. And if you'll notice on the right, you'll see that you'll initially have a 2.3 mil hole for your larger anchor, the 2.3 mil anchor, which will then move on to a 4 millimeter size in diameter. So that's effectively what's stopping that anchor pulling back through that bone, is that you're going in at a 2.3, but you've got a 4 millimeter anchor and sitting in that cancellous bone. Good. So just looking at the different implant specs, as mentioned, there's a 1.4 option. So this will typically be used for your extremities and your small fixations. So we'll have a single loaded 1.2 mil X-braid, which is your tape, or a number 2 force fiber. The anchor length is quite small. It's only 8 millimeters. So you can use it safely in your wrists and your ankles and your smaller joints. The drill depth is 60 mils. So again, not that deep. You probably won't have the worry of drilling through and obviously through the other side. And then moving on to the 2.3, it's double loaded again. So I think this is the one that Professor Funk uses. He uses a double loaded construct for his pectoral major fixation reattachment. And that comes with a tape option as well, which I think is typically the go-to option for your pectoral major reattachment. And the anchor is a little bit bigger, 12 millimeters in length, and the drill is a bit longer as well. Again, you have force fiber and tieable tape for that particular anchor. So yeah, what are they great at and what do they do? So yeah, I mean, look, I think they've been around for a while now. There, of course, was some reluctance to use them in the early days. Issues on pull-out strength were always going to be an issue, bearing in mind it's a much smaller anchor. But we now know there's a considerable body of evidence that shows that these anchors are sufficiently strong enough to be used, and in some instances actually outperforming peak or metal anchors. So another particular benefit is that the drill hole is much smaller than that of a normal peak or metal anchor. So that's removal of real estate, which is important, and obviously that greater tendon to bone contact, which is important obviously for reattachment purposes and establishing biological healing. And then another great little feature is that they're disposable. So everything is within the packaging. So your drill guide, and the anchor is all this. There's no need to be having anything sterilized and coming back. It's all inside the package. And then, yeah, in terms of what it's used for, well, it's used for pretty much any ligament or tendon reattachments. So obviously, Prof spoke about the pec major repair, and obviously for your proximal distal bicep, open rotator cuff repair, and then a range of others, small joints, knees, hips, and a few other areas as well. And that's it. So yeah, just a little overview for you. Thank you for your time. If anyone needs to reach me or get a hold of me, my details are below. But yeah, that's all from me. Thanks very much.
Thanks, Allan. Thanks for a quick introduction to all suture anchors. We all use all suture anchors in our practice for various surgeries. I mean, it's not just a question to you, but probably a question to everybody. Have you guys seen any problem with all suture anchors, any suture breakage or pull out in your practice? Matt, Prof?
Well, for me, it's just it needs to be in good cortical bone, and the anchor needs to open up like a roll bolt on the other side. So The only failures I've seen is where the bone's a bit soft or I've been using the wrong drill bit. So the key is once you put the anchor in, using the technique as per the company, then to really give it a big pull. So, you know, almost you want to see the humerus lift off the bed, and then you're okay. I can't recall seeing any late failures yet. Maybe Matt's seen some other failures.
No, I think Len's absolutely right. I think one of the things I'm quite cautious about is when using the burr, not to decorticate too much, just so you still maintain that element of a cortices to get the strength. But no, the pull-out strength's very good with them. You just need to make sure you're not aggressive with the burr. Tickle it, don't burr it.
Prof, you mentioned a very important point, isn't it? Checking the length of the drill bit, because it all depends on how thick the cortical support you're going to get, isn't it? If you go too deep, you go too shallow, you are a problem. That's correct. Have you guys seen any sort of a tunnel widening or cyst formation with the all suture anchors?
Not at all. We did an RCT which we published. I don't know if Matt was involved in it a couple of years ago, with no difference comparing an all suture with a biocomposite.
Great. Any questions to Allan from you, Matt or Prof?
No, just like to say thank you very much for including us, and I learned a lot, so thank you.
Thank you very much for the invite. It's very well done. Thank you.
Thank you, everybody. Just a quick question to Prof regarding the allograft you mentioned, Prof. Not many people across the globe would have that luxury of having the the graft bank where you can retrieve allograft. Do you suggest any other options in the chronic tear in pec major?
Yeah, I mean, I'd recommend hamstrings then. So I'd be wary with fascia lata, because the fascia lata, in my experience, when I have used it, is very variable, fascia lata autograft. So hamstrings probably the best to use.
Great. We did publish our results, isn't it, in 2010 about pec major. You have a particular sequence of tying the knots when you want to create that footprint. Do you want to share that?
It depends, and I'm not sure what you want to get at, but it depends on how it lies. So the key is in the tension. So I'd either start at the top at the bottom and work my way the other direction, depending on how it wants to lie. What was the answer you were looking for?
Just some tips to share with the viewers.
Oh, okay. Good. I was worried. I hope I gave the right answer.
Matt, with clinically and EMG wise, what do you think the role of the biceps?
Some people talk about the head depressor, don't they? Yeah, it's interesting. None of us fully know yet. They talk about the secondary stabilizer to the shoulder. I think it does contribute, when you see it. But the big worry is when it's pathological as well. So when it's diseased, inflamed, you can see why it causes so much pain and impacts upon the function. So my answer would be secondary stabilizer, head depressor to a certain degree, but it's one of the key cogs in a big machine that needs to be functioning to get the function there, particularly when you're high level athletes, because they're functioning with at such a high level that even losing that last little bit can push them down quite a bit.
Great, guys. I'm just mindful about time. I just want to thank you all for your precious time on Sunday morning in UK, as well as being a Mother's Day. I just want to kind of briefly touch on our next webinar, which is on 11th of April. We will discuss on another challenging topic, management of rotator cuff. I would like to kind of highlight that if you have, or this is for viewers, if they have any questions, they can email it to me on nweeducationacademy@gmail.com. And if they are keen on getting some clinical visitation, providing COVID situation allows us to do that, please feel free to write. So I would like to thank Stryker for educational support and OrthoTV UK for kind of collaboration regarding the platform. Thank you, everybody. Thanks.
Ravi, can I take this chance of thanking all our speakers? I think Prof, Matt, thank you once again.
Thank you.
Thank you, everyone.
Thanks, everybody.